I'm really excited to be having the conversation we're going to have today with my guest, but I want to preface it a little bit. I was telling her before we hit record that I considered myself, pretty well versed in hormones. I'm a health coach. I work with a lot of different women, heard a lot of different stories. I have my own story. I've been on bioidentical hormones since I was, 51, and I'm almost 64 now. So I thought, okay, I know about this. And then I was watching a podcast that my guest appeared on, and I heard a few things that I didn't know. So this is going to be something that's going to be very helpful for you. Um, Regardless whether you're in perimenopause, menopause, or even if you're younger than that and you haven't hit that perimenopausal window, you're going to find all of this so relevant. Today, I have with me Dr. Sarah Daccarett. She is a board certified physician. She specializes in women's hormonal health, integrative medicine, and longevity. She's had extensive training in hormone optimization, autoimmunity, which is an interest of mine since I do have autoimmune disease, and metabolic health. Dr. Daccarett blends evidence based medicine with holistic practices to help women regain balance and vitality at every stage of life. So, whether you're midlife, earlier, or well beyond. Her mission is very clear. It's to equip women with the knowledge and tools to thrive at every stage of life. Dr. Daccarett, welcome to the show.
Thank you for having me, Carol. So excited.
So I want to start out with why are women, because this really interested me, why are they being prescribed outdated HRT? What is happening here? Because I didn't even realize this was a thing, outdated HRT.
I love that you brought it up. You started with it right out of the gate. It's like, why we are still prescribing HRT like it's 1990. We've not made any innovation or advancements or progress for women in decades. And we're doing it because we feared it for so long. We thought that it was dangerous or that it caused cancer. A lot of the initial studies were misinterpreted. Doctors forgot how to prescribe it. They really did, it wasn't in the training or it was eliminated. And then now, even though there are longevity specialists and hormone replacement therapy specialists like myself and people who do specialize in it, they're still using outdated practices. And I'm so happy that everybody's talking about menopause now. Like 10 years ago when I was going through it, nobody was talking about it.
Same.
Right. And so, but now we feel like it's really great that we're getting out there that people need to be treated early, women, people, like we need to be treated early and effectively, but nobody's talking about the formulations, how crappy they are for women. And it's like women need to understand that not only do the hormones matter, the ratio matters, like which hormones you're doing and the amounts, but how you're trying to get it into your body. Because hormones are just like any other kind of a drug when we look at it, that they may not effectively get into the body. Our liver metabolizes it. What happens once it gets into the body? How are they eliminated? And it's important and it's not being talked about.
I'm really going to want to dive into one particular hormone that I knew was important, but I didn't realize how important till I listened to your podcast interview. But I want to kind of back up a little bit because there's this tendency to think about hormone replacement therapy as just being for midlife women or women who are menopausal or have already transitioned through menopause. But from my understanding of your work, it could be something that we address much earlier than that, like maybe even before age 30.
Absolutely. Like this is also, not only are the formulations outdated, but our whole approach to women is outdated. You can even look at like what we were doing for men like a decade ago. We told them that it caused prostate cancer, that it was dangerous, that they had to keep their levels really low, that they couldn't get started till they were older. We gave them creams like a testosterone cream. We did all this for men a decade ago, and then we realized that the creams got all over everybody, the kids and the pets so we stopped giving them testosterone cream because they weren't absorbing through the skin. And now we've rebranded testosterone. It's great. Everybody wants it. Even women want it. And they think that it's a good thing for everybody. And so we've changed how we approach. And now even 25-year-old men, I mean, I know some of them are still having a hard time, but in general, it's okay. Like if they're not making the testosterone, we give it to them. Like they have no issues getting the testosterone. Women, Now, fast like we're still here in the same place where we're giving women topical creams, patches, pills. Like we don't even give them an effective formula. We tell them that they have to wait an entire year for their period to stop before they can be eligible for estrogen, a
Mm,
hormone that's like been effective their entire life, and we're making them wait. What if we told men, no, no, you have to wait until you can't make sperm for an entire year before we'll give you testosterone and placenta?
wow.
It's absurd. Like, why would we tell women the same thing? We it's very like, why shouldn't a 25-year-old woman who's really struggling, tried everything else, literally, and struggling, why are antidepressants, Adderall, sleep aids, and all these other really, that we prescribed before, why are they given before her own natural hormones? Like, why is that a thing? And it shouldn't be. So why is birth control also like such a, like, why are we giving women who are perimenopausal or even when they're young? That's the like the catch-all fix for everything. Like, here you have acne,
Mhm.
you have heavy period, you have birth control. We don't make a fake synthetic hormone for men and give it to men. So there's really this huge gap in the way that we approach, like even just the way we think about hormones. We use them for a treatment for women right now. Like, hey, if you have debilitating hot flashes and um, pretty much that's it. Like you have painful, your intercourse because your atrophy is so bad, we're going to wait until you're suffering for like a year and then we'll give it to you as a treatment. Hormones are not a treatment. Hormones are the foundation for good health and longevity and anti-aging, and we should be thinking about them in our 20s. We can prevent a lot of diseases. You can't really treat heart disease and Alzheimer's and osteoporosis. You have to prevent it. And if women understood how powerful these were for preventing even just the wrinkles in their skin, this is a lot better approach than Botox for you. You know what I mean? Like, I think women just need to like view the hormones differently, that they're as essential as like a vitamin D. They're essential as brushing your teeth. It's something that we should be thinking about at a really young age and making sure they're optimal. And this approach needs to shift. And this is kind of revolutionary, even just nobody thinks about hormones this way.
Very true. I'm thinking back on my own, just through the decades, going backward in my mind. And I realized just recently that I was having hormone issues in my 20s and for sure in my 30s. I had, very, very heavy periods, very painful periods, bad PMS, struggled with infertility, really just so many different things began to happen to me. And I remember turning 30 and like suddenly having outbreaks of acne on my back. And I didn't even have acne when I was a teen at all on my face anywhere. But I think there was kind of an embarrassment to it, you know, looking back at, the 80s, the 90s, you just didn't have these open conversations with your doctor. And I don't know, I feel like maybe I would have been dismissed, like, hey, you're a young woman. What's your problem?
Absolutely. Like I look back too, and I had problems in my 20s. Like I think, and then how much do we attribute birth control to that? Like I went to birth control, and maybe I never recovered. Maybe it's the same for you. I don't know. You like your own personal. We have genetic single nucleotide polymorphisms. Like each of us are different. And I always thought, what if I'm a fast metabolizer and I metabolize really quickly, meaning that I methylate my estrogen and get rid of it. And so that's why I had problems in younger years. And no, you're dismissed. You are like women are still dismissed. Like if you are under the age of 50, you're like dismissed. I know like we're getting better at not dismissing 40-year-olds, but I bet you like the 30-year-olds are, you're too young, you're crazy, like you need to change your diet, you just have a leaky gut, you have high cortisol, you're not exercising, you are the problem. You're not doing enough. That's what we continually tell women, that they need to change their behavior when it's our fault. Like medical community needs to be supporting. We need to figure it out. Like why are we keep putting it back on women? We figured it out for men. Like so I really think we're still failing women. Yeah, it's actually like very sad. And I think that this is if they go to a traditional doctor and they're 30, if you're 30, you would have either been dismissed or birth control would have been offered to you. And women
Mm,
don't even understand like the difference with birth control and what their natural hormone is. We call birth control hormone, and that's very confusing for women. They're just chemicals. They're literally this like chemical that doesn't even exist in nature. We derive it from testosterone. And you take it, it goes all over your body. It's not local, like these local vaginal rings and stuff. That's not local. It's like literally in your stopping your brain from ovulating, from creating this like feedback loop that makes you ovulate. it makes you infertile. Like it takes your hormones and makes them zero. And we give no informed consent to women. We're not telling this 20-year-old that we are going to potentially give her disease later in life because we're dropping her hormones, that her mental health will suffer, her skin and hair and everything will suffer from that. We don't tell her that she's increased risk for stroke. This is where, if the studies show anything bad about hormones, I'm using quotation marks, it is from this synthetic progestin, which we even call it something very close to progesterone. And this has been devastating for women's health. Like calling something that's so synthetic and not natural and very similar to what our natural thing is. And then we study it and compare it. And then we extrapolate all this information and say that all hormones are bad and all hormones cause this problem. Women are very confused still.
Mm. So what is happening when women go on the birth control very young? Because I remember going on it, newly married, and I thought nothing of it. Everybody was on the pill, and I had no idea what it was doing to my body. Not once did someone explain to me. Of course, it was the times as well. Those conversations weren't being had. But what are the consequences for long term birth control use?
It's something that like we are not like we'll tell doctor, we'll look at the data, quote unquote long-term data, and be like, oh, there's no known impact to fertility, there's no known impact to health. But I would argue that even from a basic physiological argument, there absolutely is an impact because you're lowering your protective hormones. Like if women understood that estradiol, progesterone, and testosterone were the CEOs of the body, every process, like breathing, sleep, blood pressure, hair growth, bone health, your muscle tone, like your brain, how it even cleans itself is at night, is regulated and dictated by hormones. Your immune system, which I had immunity as well, like in my autoimmunity in my 30s. And this is where I really started to dive into it because you realize how complex women's immune systems are and they require hormones. And when they're gone, you get disease, like you get autoimmunity. Are the women that were offered birth control as a 15-year-old now the 25-year-olds that have endometriosis and polycystic ovarian syndrome potentially? Like this young group of women that we're seeing suffer from really low, they have all the symptoms of really low hormones and they're in their 20s. They're those the ones that have been on birth control? I don't think anybody wants to open the Pandora's box, which is what it is. Because once we open it, we'll see like what we've kind of done to women. And one, we have liberated them because we've given them a birth control option. But birth control is just that. It's all it is it's for a reason. But now we've used it for a treatment for everything. Acne, as I mentioned, heavy periods, to regulate periods. It's used for hormone replacement therapy. You have mood swings, then you need the birth control. Birth control is just, the risks for it are too great to be used as a treatment for anything else. It is only a birth control. Like if you have this, if pregnancy is it's not an option for you and you need something, then the benefits of birth control outweigh the risks because the risk of pregnancy is so great for you, right? So it's really this risk benefit that women need to weigh. If they don't want to get pregnant, then you have to take the risks of the health problems, right? So, but they can't look at it as this like safe thing to stay on for 40 years, which is what's happening, or 30 years, 20 years is really what women are staying on the birth control for. But you're right. The consequence of lowering these is and then even when we see we have it a name now, we give it a name, post-birth control syndrome, where they'll take the birth control and then they can't quite recover this feedback loop that's supposed to happen. Where the brain is stimulating the ovaries to ovulate and then they're having trouble getting pregnant, so now we have what is causing all this infertility. Well, part of it could be because they were on birth control for a short period of time, even though we tell women that, oh, it's not going to hurt your chances of getting pregnant. But absolutely is, of course, going to do that. It's so I'm all for it, right? Birth control, women need, but when it's not a birth control discussion because it's like women need a choice. I think the only thing is that the take home message is, look, women, you need a choice. We're giving you choices and you need to be informed about it. Make sure that you just know that you're taking the birth control and you know the risks, and that's okay because you've agreed to that. Right now, that's not happening. And then when you decide to do hormone replacement therapy, same thing, that you're fully informed of like what you're doing to your body and why and the benefits. So it's really like women have to take charge because their doctors aren't doing it for them.
So really being informed about each choice and making the best choice for their body. What do you think, birth control wise, for a young woman? What is the best choice? I know this is a struggle with my, speaking with my daughters. I have daughters in their 20s. How should I be advising them, or how should their doctor be advising them? I should say.
You should do it. I always say that if you don't teach your kid about sex, somebody else will. Like this is something that
Right.
should come from like women. I don't think our generation was told, like talked about, like women don't know about their periods or their cycles or how to predict potentially like when they're ovulating. They don't even understand like period cramping and how to get rid of it, or like steady bleeding, and a lot of it they don't even understand. I'll talk to women today that don't even understand where the vaginal wetness comes from, like where vaginal dryness
Mm.
originates. Like we know they understand erections and erectile dysfunction in men better than they understand their own bodies. I think that normalizing this for teenage girls and like being like is really, really important. Like if we talk about everything that's sex related, so there's not shame around it and our own bodies and the period and sex and masturbation, everything we need to talk about teenage girl about, we should be. And this includes like the birth control, but if we taught them about their cycle at a young age, you can use combination efforts. I have a son, I don't have a daughter. So, but I've often thought about it that you could theoretically do like a rhythm in combination with a somewhat effective, like condoms are 80% effective. And then if you combine it with a rhythm method, you could get substantial like coverage there. So there are options for, potentially for that.
Mm. Now, what about the IUD? Because I know there's two different options there, right? Like the traditional one, and then the one that has the progesterone, but it's an artificial progesterone, synthetic, I should say.
Yeah. It's a marine, like progestin only IUD. Those are synthetic too, and they're still doing the same thing. You still see these, the same effect. Like you're going to lower your hormone levels and do the same thing. Like, so anytime you're, causing infertility, and I think there's a report that birth control is like 99% effective for these IUDs. I don't think that like women get pregnant on birth control all the time. So is this more effective than just using like a rhythm method and a combination of a condom? And I think I think I've heard some providers say that like we see women, these are not fully effective either, this IUD or birth control. So like, right, they're not necessarily they're not 100% effective against pregnancy.
I remember the side effects on birth control pills. It was, for me, it was a lot of bloating, especially through the stomach, and you could see it in my face. Um, Kind of moody. I was sort of moody on birth control.
You've had all of the symptoms of perimenopause. So this is like the thing,
Wow.
like when you take away all these hormones, you're putting her in a perimenopausal state. She gets like literally and even a menopausal, right? There's not even a period. I mean, it's like the idea is that anxiety, depression, irritability, bloating, weight gain, acne. If you look at all the side effects of birth control, they're the same as perimenopause side effects. Like this is like you're putting her in this state where she's going to feel perimenopausal.
Wow. See, I so wish I had known these things, but that wasn't even a word. I remember perimenopause wasn't even, I heard about it, I think, for the first time when I was around about 40, but then I was told, oh, that's not really a thing. That's not really a thing. There's menopause and that's it. And finding out later, oh no, it's a roller coaster ride when I experienced it myself. And now we're going to skip forward a little bit. So, a woman she's perimenopausal or she's transitioning through menopause. What is the hormone that you think is having the most profound effect at that perimenopausal window? Like, what is fluctuating the most? What is having the greatest effect on her symptoms?
So I think to just make that a little bit bigger, I get what question you're asking, but like a little bit bigger scope is we tend to view a woman's main hormone as estrogen and or testosterone. Like really when you look at and let's get into like the amounts and the reference interval, like the actual range and the
Right.
units and why it's so confusing. But in general, like at any age, progesterone is the main hormone. Progesterone. And then estrogen and testosterone are generally close to the same amount actually in women. So like this is kind of very what nobody thinks about it. Like even doctors are like, oh, it's just needed for pregnancy. Well, progesterone is just this like really pregnancy related hormone. But what just like men have their main hormone of testosterone. Let's back up. Men have all three hormones. They have testosterone, progesterone, and estrogen. Okay.
Mm.
Testosterone is the main hormone for them, and they make estrogen from their testosterone. Okay, so women are the same. We have all three hormones. Progesterone is our main hormone, and then we make testosterone from progesterone, and we have estrogen around too. So it's kind of like the sexes are not so different in relation to these sex hormones. And when labs report this, doctors are confused by it because we get zero, well, just like we get 0 hours of menopause training, we get 0 hours of laboratory training. Like doctors are not
Wow.
taught how to interpret lab tests. Like you think they would be, even so they're not. So the range. So progesterone, when it's reported on the lab test, and anybody's got a lab test, it'll say like two, like give the number 2 for progesterone, or 6, or like as high as, like 10 or 12. And everybody thinks that's like a nothing because it's such a small number, 10. But when you look at the units, it's nanograms per deciliter, which is when you put it in the same units as estrogen is, that's 10,000. That's 2,000. That's 6,000. That's in the thousands. It's just that the lab doesn't want to fit it on the lab report. So they make it a 2 and then change the unit. This is literally like what they do. I work for labs. I'm a medical director for labs. This is like what we do. We don't think about how a doctor is going to see that. So we're just trying to get it on the lab report. And then the estradiol, and then testosterone too. We even changed the units on that so that 10 or 20 or 30 that you see is actually 100, 200, 300 if you put it in the same units as estrogen. So that's why we do need to give testosterone its credit, and like how much does play a role in women, but not as much as progesterone. It's like magnitudes higher than the other ones. So when you get into perimenopause, what happens is, I don't even like using the word, as you mentioned, it's like, why is it even a thing? 25-year-olds could be quote unquote perimenopausal, but she's like, we don't have to define it as like a decade out of having your period stop or anything like that. It's women, if you're out there and you're having problems, it doesn't matter what your age is. Like, you have to stop thinking that you're too young. Like, if it's happening to you, it's your reality. This is what's happening to you. You have to accept it and figure out what's going on. You don't have to wait until you're 30. Okay, now I can say I'm perimenopausal. So that's not what we're doing here. But I know you're not doing that, but we do that as like a community. So the women, when you get to a certain age, and it's just aging, it's nothing you've done. You didn't do anything wrong. So what happens is the ovaries start failing, they start fatiguing, and it can't make progesterone, which is our main hormone. So the brain freaks out, starts releasing a substance called FSH, which is follicle stimulating hormone. This rises. This is something we never order on a lab test either, but it gets bigger. It's a sensor of what the brain is thinking. The brain doesn't think that there's enough hormone around. It signals the ovary, and the ovary's like, I can't do it, I'm failing. And it will make spurts of estrogen, though, because it can do that, but it can't make the main hormone, which is progesterone. Women will get a lab test. Progesterone will be like in the toilet, and so is testosterone, because we need progesterone to make testosterone. So both of those will be low, but there will be like a spike of estrogen. So then they are told that they have estrogen dominance. You have too much estrogen. You need to lower the estrogen. Estrogen is your problem. Estrogen is what's causing all of your mood swings and all of your symptoms. Instead of saying, no, your ovaries are failing, you need all three hormones. Like, you can't make anything, and you barely are making estrogen on a regular basis, and it's not being balanced correctly, because progesterone needs to be at least 10 times higher, if not 30 times higher than your estrogen, right?
Wow.
This is the one that needs to be the highest. So women are taking supplements and eating fiber and DIM and everything to lower their estrogen during this time, and avoiding quote unquote estrogens in the environment. And this is really messed up how we're viewing it. And then they're only given progesterone, some of them, and they're given this like one hormone approach. And this is also like very devastating, that women aren't even just kind of like looked at, in the sense that we don't know anything about her main hormone. There are 5 papers in the entire world about progesterone and what the optimal reference ranges should be. I say that is it 10,000? I don't know. Some doctor could say it's 6,000. I could say it's 4,000. No, none of us know, because there's not literally not a study on it. So,
Wow.
and this is like, there are hundreds, thousands of papers on testosterone, like in comparison. Okay. So one, it should enrage anybody who's hearing this, that they literally have not studied our own main hormone. But women who have been told that they're, this perimenopausal state of, this is just your ovaries failing. And if so, what happens then if you take estrogen? Because everybody's told you can't take it because it's high, right? Like, you're during this perimenopausal phase, what happens is when you start taking both progesterone and estrogen at the same time, the brain calms down. Like, it basically tells the ovaries that, okay, we have enough hormone around. It lowers FSH, and your own ovary stops trying to make erratic estrogen, which is what it was doing before. And you end up actually with lower amounts of estrogen, the appropriate amount that's right for you. And it kind of, and then everything ends up in the right ratio: progesterone, estrogen, and testosterone. And that's where you get this stability, and you stop this roller coaster ride that's happening in our 30s, basically, is when the bulk of us are kind of doing it. It's not, you're suppressing your own ovarian function, so this is the approach that we need to be thinking of, instead of like, I think you kind of can see the difference, because women are being told to, like, oh, you have plenty of estrogen around, you're 35, you just need to take progesterone at night to sleep. And then I think we need to talk about the problems with doing that to young women. Are we giving, increasing her susceptibility to autoimmunity by doing that? I think we are. Like, we need to be really like a whole body. When we do hormone replacement therapy, we're not thinking about her immune system. I think this is one of the biggest mistakes that we make, is that we don't respect a woman's immune system enough. And so even when we don't recognize that she has autoimmunity because her hormones are low, and then we don't recognize that we could potentially make her autoimmunity worse by the way that we're doing the hormones for her too. So it's literally it's like a massive problem.
I have to admit, I did not know there was a link between hormones and autoimmunity. Can you speak into that a little bit? That's just fascinating to me. I honestly had never heard that.
The the easiest way to describe it is to look what I study women, and I switched to only women because I think they're fascinating. Like, in terms of like
Mhm.
the biology and the physiology, they're much more interesting than men. And that is, the immune system too is more complex. So if you look at what women are capable of doing, we have to get pregnant. Well, we don't have to. I'm just saying, like, when we get pregnant,
Mhm.
we have to have an immune system that is strong enough that we don't get sick during pregnancy. Because, like, think about it, we're in kind of a vulnerable state. We have to carry this and do this pretty miraculous thing with the body, and carry a baby and not get sick from a pathogen like a virus. And then at the same time, our immune system cannot attack the baby because it's a foreign object in the body. So the immune system has to recognize it, and like that it's not foreign, and so it has to be extremely orchestrated and organized during pregnancy. So it has to be elevated, like boosted, and it has to be modulated, which is what the word we use to describe, like, you're not going to attack yourself or your own baby, because essentially, like, it's self. Can you imagine if we all like started attacking the baby? It would be
Wow.
during pregnancy. So it's something like this is nature has evolved to solve this problem. And the way it did it is it raised, when you get pregnant, estrogen gets up to 40,000 picograms per milliliter. Everybody talks about, oh, 1,000 on the lab test is high. I'm like, that's not high. Like, pregnancy is like, estrogen gets up really high during pregnancy, and then progesterone gets up to 300,000, which is 300 on the lab test, but it's actually 300,000 picograms per milliliter. So progesterone is like massive amounts during pregnancy, and the placenta is the one that's creating this hormone milieu. And so the estrogen and progesterone bind directly to these immune cells, the B cells, the T cells, the NK cells, like everything in the immune system. It's like 12 dimensional, like, will bind and it will regulate it and kind of be this orchestrator. So estrogen boosts it. It makes us have a strong immunity. Like, if you're getting sick during the winter, but yet you have eczema all over your skin, you have a dysfunctional immune system, because your estrogen is not high enough to keep you fighting viruses, and your progesterone is not high enough to keep you from fighting your own skin. So, like, women need to understand that we need both in order for this immune system to work correctly. And in pregnancy is like the most perfect example of how it works perfectly. So again, if you are, and then autoimmunity, literally all autoimmunity is this dysregulated immune system, where you have this chaos where the immune system starts fighting yourself, but it's not fighting the virus. So anybody with autoimmunity knows, like, hey, I'm the one that gets the sickest during the winter. Like, COVID was a disaster. I got sick, really sick, and then whatever, influenza. But then I really find that I'm sensitive. Like, my immune system is overreacting to everything else that's around me. It won't fight the right things. Okay, so this is just mild autoimmunity. It's kind of even like and then it's like a spectrum. You can have endometriosis, like you can have Hashimoto's, you can have it attack certain glands that we can measure. You can have rheumatoid arthritis and multiple sclerosis, and women carry the bulk of autoimmunity. I think we get 80% of it or something like
Hmm. We
that.
do.
So it's because men don't have this complex of a system. They don't have to carry the baby or whatever. So when they're told like, oh, I had Hashimoto's and I need to just fix my Hashimoto's and then my hormones will be fixed, it's the other way around. Your hormones dropped and then you developed Hashimoto's because your hormones weren't correct for you. And I don't like the trend of telling women that they have some kind of childhood trauma. I've heard this like that now they have autoimmunity
Hmm.
because of childhood trauma.
Hmm.
I think it's purely biological that women who have autoimmunity also tend to have probably anxiety, depression, irritability, and a mental health state because their hormones are low. Like we need progesterone to maintain like good mental health. So the women that have autoimmunity are of course going to be highly anxious individuals because they have no
Oh,
progesterone.
yeah.
You're ignoring this like very basic thing for her and you're trying to like, we treat it all different ways. We ignore it, but and then when you take hormone replacement therapy, you need a form of progesterone that will be effective to treat this. Like oral progesterone, I'm sorry, is not going to cut it. Like if you have autoimmunity and you're trying to treat it with the oral progesterone or, take care of this, it's not going to work because of the way that it's metabolized in the body. And then plus if you like your testosterone, I didn't even talk about how testosterone impacts this, but it probably makes it worse. Like, so if you're imbalanced and you have too much of one and then you're disrupting this like like testosterone is not high during pregnancy, right? So like testosterone is like it's just its normal state, which is what it probably is, like 40-ish the whole time. Like it doesn't raise. So you want to make sure that in hormone replacement therapy that if you're doing like an injection or a pellet, or women need to know that if they put testosterone on their skin, this converts right to DHT, this pathway, this like is there's high converting to this metabolite, and that can disrupt the immune system or make your hair fall out. Like, first of all, like, with these side
Hmm.
effects of, and then, or if you inject testosterone, then you tend to convert to estrogen. And are you disrupting this like kind of balance too much and then making sensitivity to the environment worse, which women who inject testosterone may even report that. They'll say that they have like these histamine reactions and stuff. So this is like, so it's so complicated, but it's yet so you just shows women how complex they are. You don't have to understand what I'm saying, but know that you need to find somebody who's thinking about it, and you need to think about it. Protecting we'll talk about anti-aging. All the diseases of aging could potentially be immune related: heart disease, diabetes,
Hmm. Yes.
dementia. So
Inflammation. Hmm.
inflammation is like mild autoimmunity in a way. Like it's kind of this like spectrum of you have this dysfunctionality in the immune system. If we can preserve it and keep our immune system really healthy, robust, and young, it will help us age really, really well too. So um, it's very important that we get it right.
Mm. This is also interesting, especially, I have autoimmune. As I mentioned, I have RA. I was diagnosed, about 10 years ago, but I think it started much sooner. And some of the things you're saying, anxiety, had it my whole life as far back as I can remember. And then also a tendency of my immune system to always overreact, like severe allergies. My mother had such a time with me. Anything she put on my skin, set me on the grass. It was just these extreme reactions. So it starts to make sense. You can kind of look back, hindsight's 2020, right? And see and go, oh, wow, this was an issue for me long before I realized it was an issue. Now, you mentioned something about progesterone, the oral not being the best method. Why is that? Because we always hear, okay, take one at night. And honestly, that's what I do. I take progesterone at night.
So rheumatoid arthritis like develops years. It takes years to develop. So you're right. Like it started happening, in the oral progesterone, 80% of it is metabolized by the liver.
Mm,
When you swallow something, it undergoes this metabolism and the liver gets a hold of it and it breaks into metabolites that I would say we don't really even know what they do. Like, so we know that the ones that make us sleepy, they're basically an anesthesia effect on the brain, which is why when you take oral progesterone, you fall asleep. Like that's a great
hmm.
sleeping pill. I would
Yeah.
say it's just like a sleeping pill. But those other metabolites have the potential to convert into something like testosterone. So, one, it's not effective because if you take 200 milligrams of oral progesterone, That's only 20, maybe 40. Like, let's give it like some credit. So it's 40 milligrams of progesterone only. It's not a lot. It's not enough for, I have autoimmunity as well. So like, I agree that like to treat like and boost, like if you're looking, like this is an interesting thing about oral too, is that doctors will say, oh, but the lab test came back at like 10,000, which is 10,000, just like, so they're saying that the oral progesterone gets the serum levels high enough. We're not talking about bioavailability here. So most of that oral progesterone, even though the serum levels are higher, I would argue is not bioavailable for the body to use. So, you might, and even women, you don't have enough to like suppress heavy bleeding, right? So like the oral progesterone doesn't suppress that in some women. So if you're not even suppressing like a menstruation, how are you going to suppress your immune system or like kind of orchestrate or modulate the immune system? I took oral progesterone for a long time. I tried it for a long time. I've been doing this for a decade. And so I obviously tried all the dated stuff and did that. But I would argue that the reason why progesterone is our main hormone. We talked about how critical it is. We talked about just one thing that it's critical for, which is the immune system, but mental health and sleep, and it is literally like for so even great skin and hair. We give estrogen a lot of credit, but progesterone is like what kind of keeps this like nice base to the skin. It helps give that glow. I would argue that this hormone is the hardest to get into a body. And that's maybe why nobody's innovated or solved the problem for women. It doesn't go through the skin. It's too big. Like when you look at it, it's like a big chemical. It's a molecule. It doesn't really go through the skin. The skin is a barrier. It's supposed to stop stuff from going into your body, but it doesn't. Of course, we know that when we put lotions and fragrances and stuff, it goes into the body, but progesterone doesn't. So it's only like 20% of that gets in. When you swallow it, the liver gets to it. And then the liver is not meant to take the bulk of metabolism of hormones. Like naturally in the body, when you make it, your liver doesn't metabolize it when you're in your 20s. What happens is your ovaries make it, and most likely your uterus does the metabolism because it's right here and you get this first metabolism. So this area is metabolizing it and making the appropriate metabolites to keep your uterus healthy. There's metabolites that the uterus makes. One's called DHP that is very potent anti-inflammatory. And it also like goes right to the central nervous system and helps with like mood, right? And it also regulates bleeding. So I would argue that the uterus needs to be doing the metabolism, not the liver. And then and then the breast is like our breast and uterus, they are endocrine organs and they do a lot of metabolizing. We give the liver credit for metabolizing hormones, but in nature, are they really supposed to be metabolizing hormones? Or is it the breast and the uterus and tissues like the brain and other organs metabolizing it? It's probably done everywhere. Well, if you think about it, every tissue probably metabolizes it. So thinking about so when I sought to solve the problem for myself, which is really like what I wanted because I wanted to feel better. I had RA was my autoimmunity as well. And it was just, this was something that I was like, you could see progressing. I didn't want it to get worse. I also it was like a train wreck. I mean, anybody that's gone through it is like, just knows like, he's like, yeah, totally. Me too. Like, it's fine, but you don't have to get into it. But I wanted to feel better. I was only 35. I wanted to look good and feel good. And I sought out to solve the problem. And when you look at all of the formulations for women, they suck. And they don't get progesterone into the body well enough. Okay, so you can inject it. So this is like an okay way to inject it, but we would have to inject a lot in order to get the amounts that we need. I told you how high it gets during pregnancy.
Right.
I mean, so like women arguably need, we are being microdosed. Like anybody out there is doing hormone replacement therapy, like you are being microdosed. Like we do not, we pour testosterone on men, right? We give them plenty. These are really safe things. And we completely microdose women. We give them just enough to like stop their hot flashes. We give them just enough to like treat their vaginal dryness so they're not like crying in pain. And then we just treat just enough. Like, just here, well, let me give you progesterone oral. And I'm probably upsetting a lot of people listening, but it's like, I feel like women need to be upset about it. In terms of progesterone's like a sleeping pill. Like, here, get out of my office, just go to sleep. Like we're giving them solutions that are like really patchwork. Here to put a patch on to take your hot flashes, do a low dose vaginal cream to treat your vaginal dryness, take an oral pill to help you sleep. Now you have to put an estriol cream on to help your wrinkles, and you still have to do hair serums. And oh, by the way, you're still gonna have to wear like a weighted vest in order to get your bones to like grow. And like you're just gonna at least like, and then some testosterone cream on top of that, because we can't figure it out that we have to give you like 8 different solutions, which none of them are really solutions. So it's this is so, I don't know if that makes any sense, but
It does. It
yeah.
does. What are the best delivery methods then? Because I'm thinking of a few different situations. Okay, a woman's had a hysterectomy or a partial, so there's no uterus. I mean, how can she know she is getting enough progesterone? What is the best method for testosterone, estrogen? What are the best delivery methods here?
Yeah, it's a great question, because and even if the uterus is not present, do you still benefit from like these delivery methods? As we talked about, like the metabolites being made. Yes, it's okay if you had a hysterectomy, and I wish that women were offered progesterone before their hysterectomy, because you could just stop the heavy bleeding potentially with that. Fibroids,
Mm,
like fibroids,
yes.
Fibroids, you might still have to intervene because they tend to grow regardless, but something like heavy bleeding should not be like a reflex so quickly to hysterectomy like it is. But vaginal delivery. So this is everybody's gonna be like, nah, this is not even true. And I pretty much contradict every HRT trained doctor out there. Like they'll argue with me, and I'll tell you the problem with it. We tell women that vaginal delivery is only local. We tell them that it's not systemic and it's only going to treat vaginal dryness. And the problem with this messaging is, one, it's a myth, and it's vaginal route or vaginal delivery of hormones is a route. It's not a dose. If you take a low dose, like a microdose, like the products that are on the market, you're only going to treat it locally, right? Vaginal delivery is local and it's systemic. If you put enough hormone in it and you get it high enough, it'll go into the bloodstream. And even the tiny doses that are like vaginal, there's enough of it to be measured. We just are confirming that it's not that systemic, that we confirming that the dose is not systemic. So even doctors are not looking at the literature, and they're confused because they're saying that no, vaginal can't be systemic. It's garbage. We even know that birth control, those rings,
Oh,
are
yeah.
systemic.
Hmm.
Like we don't
True.
prevent pregnancy just by letting it. There's no ovulation that's happening in the vagina, guys. Like you guys went to medical school. The ovulation is happening in the brain and the ovaries. It has to be systemic in order to stop that process. Literally millions of women every day are proving that vaginal route is systemic. So we need to recognize that the vagina is like our superpower, in the sense that you don't have to do an injection. You can get something into the body very effectively, because it's like this really porous, membranous. When women need to know that, like, even when the vagina cleans itself, it's because fluid is like literally being pushed through the vagina walls. And that's how you get like this lubrication too. It's not glands, like glands take apart, but it's really just the walls of the vagina. Our blood is like kind of pressing through this pathway, and you get like all this fluid. So it's very porous. There's transport mechanisms that can take drugs into the body. And not only, if depending upon where you put the hormone in the vagina, it will go into the blood, and you can get this first pass metabolism effect if it's close enough to uterus. So you can get both. Like, and if you don't have a uterus, that's okay, because the idea is that you're just trying to get it into the bloodstream so that you can, and you want a bioavailable form. So like if you take it oral and it's not bioavailable, which I think intuitively women understand bioavailability. Like if you take a vitamin D pill, it's not going to be as bioavailable as if you take the food, right? If you take cod liver
Right.
oil and it's food,
Hmm.
even though it's lower amount, it's like more something that your body can use. Like the food source of the blueberry is going to be better than the synthetic vitamin,
Hmm.
right? So bioavailability, that's kind of what I'm talking about. When you have a hormone and this vaginal route can offer you more bioavailability, this hormone that you can use better. What if you can, metabolize it in the uterus and get these benefits? So this is a way, and this in itself is like a new concept, because they come to me all the time and they're like, you're lying, it's a scam. Like there's no way that, because I've been told my whole life that it's
Hmm.
only to do my vaginal dryness. And then they take it and they're like, skin looks great, sleeping, and their hair is growing, and they don't have the side effects that they get from the orals. So like women deserve like HRT that doesn't have a lot of side effects. Because the problem is with HRT is that there are side effects that come with it, and we need to make sure we minimize them. Like we want to minimize water retention and bloating at first, and you're still going to get them with the vaginal delivery, but there's a way to move past them, right? So like you can get over these over time, like in a few months, knowing that there's like some healing that has to be done. You can't avoid it sometimes, but we want to minimize this. Like we're just sometimes making this bloating really bad with the oral progesterones, or the pellets can make
I hear a lot about that. Women will say, "Oh, I started progesterone and now I'm bloating. I've gained weight."
exactly. Yeah.
Now,
It's like,
now, is the vaginal good for estrogen, testosterone, and progesterone, or is it just progesterone?
so progesterone and estrogen, and it theoretically would work for testosterone too, but women need to remember that if they put testosterone vaginally, it can disrupt the vaginal microbiome.
Oh,
So their vaginal microbiome again is like really, really
did not
important.
know this.
We need to keep
Okay.
the appropriate pH. We need to be able to prevent infections. Um, this is like an area that pelvic health is really important. So it's just, and plus, if women need to remember that progesterone converts to testosterone. And again, everybody out there I'll fight you on it all day long. Like I'll show you lab results with women taking vaginal progesterone and they will end up with normal testosterone levels. It works. Like it definitely, is it going to get you to a really high testosterone? No. But that's the point. Like a lot of women just want normal testosterone. They don't want it to be elevated because it causes acne and hair loss and bloating and weight gain. You want it to be in that right amount. That's really important that we don't have too much. And so this, if you were to add testosterone to a vaginal delivery with progesterone in it, it would just get too high. So women, and first of all, I would say that testosterone is the easiest. Like it's easy to kind of replace it. We need to focus on progesterone and estrogen first. It's like the hardest. We need to figure that out and get that right in the body. And then once you get that right, I would argue too that in the immune system, your uterus, your breasts, this healing of your gut like needs to happen first, and then libido. Like if people come in, women are like, I need a libido, or my husband's going to divorce me. It's really sad that
Yeah.
they try and like this is
Yeah.
that they act. It's like not a race, or it's like, hey, let's get these healing this done first, and once you have health, you will have libido. It's like weight loss. Like it's once you feel healthy and you're doing better, like you're gonna feel like having sex more too, and then like libido tends to come with health, and so does weight loss. So I do get like that they want the bit vaginal dryness, like completely getting rid of that will help with libido. That's like 80, a lot of it for women. If they just feel good while having sex and they feel right, they feel good in their bodies, then sex is actually enjoyable. They're going to like to do it more. So having that actual drive, I would argue that that's the reason to start the testosterone. That's like, I feel like we can get everything else from the other hormones really.
Mm.
But even estrogen and progesterone play this massive role in libido. So it's a little too much almost for an hour to talk about testosterone, but women should know that you can, we don't put it, I don't put it in my formulation, for example, because I don't want it to get too high, because we have autoimmune patients, like MCAS patients, women with mast cell activation syndrome, and I don't want to give them testosterone, and like, so too, you get these other ones elevated, and then you try to see if her body is converting it and making sure that she's making the testosterone. And if she is, great. You don't have to do anything else. Like it's okay if later, 6 months later, you have to add in something. It's okay. Like you can still kind of boost that testosterone. There's different ways. Herbs can do it. A little bit of DHEA. Like you can kind of manipulate it subtly for her that she gets just enough that she feels like she gets that libido back without causing her skin to break out, or the hair to shed or something. Like you want to have this really like fine, it's almost like a fine line there for her. So for some women, especially who overconvert, like they can make DHT and make a lot of it, and then they'll break out and have their hair shed, and you don't want that, right? So it is truly individualized in that sense. Like everybody's journey will be a little bit different.
Yeah, it's a tough one because I'll tell you what I do, and you can kind of critique it a little bit. So I have the estrogen patch. And then, of course, I told you about the progesterone I take orally. And then for testosterone, I do an injection once a week, a very small amount. But what I've noticed is when my labs are run, that testosterone tends to get too high. And it's interesting because when I first started bioidenticals, everything was flatlined. So it was really easy. It's like, oh, you have absolutely nothing. So here's your estrogen, progesterone, testosterone. And now I find that testosterone so difficult. I'm not comfortable with it being that high.
Yeah. It's hard. And like also it's taking the lab too, like right after the injection, even if you were to try to space it out a little bit, you could maybe get that. But it is like the nature of that formulation. Injection pellets like tend to get it a little bit too high. When you do the cream, you have a little bit more control over it, but then you convert to DHT and can cause like a major side effect for her. So I find that like the vaginal delivery, like our method, you have you it doesn't it never risk it getting too high. In fact, like it's the opposite. If 10 or 20% of it's too low, then okay, let's work on like you can always try to raise it another way. But when it gets too high, it's so hard to control, especially with injections and our current formulations. Yeah, and
Yes, it is hard.
it is hard. And like you don't need, and we tend to like we can get so many benefits if we just raise the progesterone and estrogen more. Like you're trying to get the benefit out of that testosterone, like the bone health and the mental clarity, because some of that's converting to estrogen, and so you could do it a different way. There's a different way, is what I'm saying, telling women. You could try, and definitely it depends on your goals and the bloating. It's like we could have a follow up podcast to talk about that and side effects of hormones and women managing them because they're lost, they're confused. They tend to stop the HRT, or they tend to think it's the dose, I think, is where they think, oh, you didn't give me the right dose or something. Like any dose I give you is going to give you bloating right now because your gut health is really bad. So they need to almost know how to like just tackle that, and then their bloating will get better regardless of what formulation they're on. So even if they like the oral because they like the pill, I just think women need a choice. Like that we're just another choice, and they need to be informed. And some women are going to hate the vaginal. They just don't like having a messy vagina, and that's fine. They like taking the pills, but at least they're informed. At least they know. Like,
Mm-hmm.
and then yeah,
So important.
and it's
So
not.
important. Yeah, to have these conversations, talk openly, try different things, see what works for you, get those lab results, kind of tweak it, balance it from there. Now, why is it so important to have the gut in check before you start testosterone?
Yeah, or even and testosterone would make it worse. I think is why it makes the bloating worse, but also the other hormones do too. So like really, women need their gallbladder to work. And this like really they need estrogen to make their gallbladder work. And they'll go like a decade of estrogen, right? So even in perimenopause, when they're told their estrogen's high, this is not true. It's just not high all the time, and they don't have the progesterone. So their digestion gets wrecked for like a decade before they start HRT. And then they eat a bunch of fiber. They're eating 30 grams of fiber a day just because they have to go to the bathroom because their digestion is like not working because their hormones have been gone. So they've been trying to fix their digestion, and then they start HRT and they still have their really high fiber diet. And that's really the problem, is they have underlying small intestinal bacterial overgrowth. They have SIBO. And then when you start the estrogen, it stimulates because even if you're taking testosterone, it converts, right? So the estrogen is converting, and testosterone is converting to estrogen. The estrogen stimulates the gallbladder. So the gallbladder can't work because it hasn't been working for a while. And the bile is what kills the bacteria that's not supposed to be there in the intestine, which is what's causing all this bloating. So literally this bloating is a gallbladder problem. And women continue to eat these. They think fibers, what's the solution? Like, so look, if you just stopped this fiber intake, the bloating would go away. And generally it does, like with just the fiber alone. If you just stopped eating the nuts and the seeds and the beans and the green leafy vegetables for a while, like you can start to introduce them a little bit slowly later. Because I get people like them. It's fine. You like chia seeds for breakfast? Great. Like I'm not here to argue diet. Like what I'm saying is a fact that if you eat all this fiber, is going to make you bloated. So like, and then also you can take supplements like ox bile, which are bile. Like you're literally killing this bacteria that's supposed to be there. Women are seeing functional medicine doctors. They're getting all these really expensive lab tests. They're doing restrictive diets. They're doing a lot for their gut. And they're probably not, a lot of them are not doing the right things that will treat the bloating or the SIBO, I would say. So they're getting a lot of confusion about this as well. And then when they start HRT, they have underlying SIBO, and then it just gets worse. So they tend to think the hormones made me bloated. Your product is crap. It's fine. It makes me bloated.
Mm-hmm.
And it's like, you are bloated because like you have this underlying problem that's here. And if you were to just do these things, then it's okay, because women realize that then they do that and the bloating goes away, and then they get the benefit from the HRT. So they shouldn't, all I'm saying is that you shouldn't be turned off by necessarily the side effect. You need to know that the hormone is highlighting a problem that you have to solve. If you have bloating, or if your uterus is bleeding when you start, your uterus has to heal. If you have breast tenderness, your breasts need to heal. Like it's something that the HRT is not necessarily doing to you. It's that you have to work on these parts of your body that are like obviously calling attention to you. And if you give them the right environment and tools, then your body can heal better. And then you can benefit from the HRT, because that's what we're all trying to do, is get rid of symptoms and benefit from the HRT. And don't let this like kind of hurdle stop you. Just keep pushing forward, like keep moving through it. Like, okay, now we got to heal your gut. Now we got to work on these other things. Hormone replacement therapy isn't like a catch-all. It's going to solve all your problems, because and anybody, and the earlier you start, the better. That's also, we can circle back here to like, if you get started earlier, before you spend a decade with your gut health, for example, women who are younger and get started, like if they're in their 30s, they have less side effects. I would say they have less bloating, they have less problems, because have been declining for that long. You can kind of imagine that women have been trying to like fix their, so it is easier if you're thinking about HRT at all, and it's, hey, this is inevitable, you're going to have to start it someday. Don't wait like until you're 55, 60. Like, this is something that you should be really thinking about when the problems are starting for you, whatever age it is. Like, if it doesn't start till you're 50, good for you. But like, it's like, if you're like it's good genetics or something, it's fine. But whatever age you're at that you're thinking about it, just know the longer you wait, the harder it is too.
That's really good advice, because again, I look back on my own life and I think, oh wow, the gut health problems started long before the hot flashes. I think sometimes there's been these symptoms, but we don't see them as hormonal. We're like, oh, I would say things like, oh, I have my father's stomach. I'm sensitive to this and that, and I realized looking back, oh no, the timing of that, it probably was a hormonal issue. I had that. And then I'll say the mental health shows up prior to the hot flashes. You get that anxiety or feeling blue or depressed for no reason. I remember once, and I've told this to the listeners before, I was like standing in my sunroom. I remember it distinctly, age 48, thinking I just heard an ad for a bipolar medication, and not to make light of mental health at all. But I started thinking, oh, maybe that's me. Maybe I need that medication. What is wrong with me? Because my emotions were just a roller coaster.
Women, the hot flashes are the last thing to happen.
Hmm.
The very, very last. Do not wait for them. Like, it really means that you're really depleted and in trouble, because it's how we regulate our body temperature. It's like,
Oh, yeah.
this is literally the last thing to lose, the estrogen. So you're absolutely right that we attribute all of this stuff to other things. Like, we don't think about, because we're being told that the hormones are later. So we attribute them to diet
Hmm.
or other problems. We need to be like recognizing that hormones drop off early. Like, this is actually a hormonal thing. And this will help a woman out, just not to push it off and be like, oh, because I'm sure you're just like, I'll just wait until my period stops and then it's a hormone. No, that's too late, really.
Hmm. And the hot flashes I mean, anyone who's ever had them knows I had them really bad. And that's what finally drove me to get help, because it was so miserable
Right?
that I didn't care about risk anymore. It's just like,
I
help
had,
me
I
out here.
had a spurt of them postpartum. I was like, whoa. Like,
Oh,
you know what I
yeah.
mean? Wow. And I'm sure postpartum women have had them. Like, you drop to like that zero, and then
Hmm.
they're not like sweating. Like, if anybody's never had one, it is like a sense of impending doom.
Oh,
There's
yeah.
a lot of anxiety. Like, it's just this feeling of your like world falling out beneath you. And it's like very kind of scary. And then it's like not fun. So don't,
No,
and
it's not.
yeah, don't, like, it's, we absolutely should not be waiting for the hot flashes. And doctors do, they make them wait till women wait. And no, you're not having hot flashes and you're fine. You're having your period. It's fine. This is garbage. Yeah.
Absolutely. Dr. Daccarett, this has been fascinating. Thank you so much. And I want to respect your time. I know you're busy. As we wrap up, a couple questions for you. Is there something that we didn't talk about you think the listeners should know? And how can they learn more about what you do, follow you, and perhaps work with you?
Yeah, they can learn more online. So I have social channels that we do videos and try to get information to women. Sarah Daccarett MD, and then Inner Balance MD. You can come online to our website. You can ask us questions if you want. We try to be a resource to you as you're doing your research, right? So if you're thinking about it and you're researching different options and you even just want some information, like, we can provide that for you. And that's innerbalance.com. So, and even if you just want to get started and try it, we have like a money back guarantee too. So it's something a lot, because what we do, as you mentioned, like, hey, because sometimes you just have to try different things to see
You
what you
do. Hmm.
recognize that you do need 6 months sometimes to try it. So it's okay to even try it. So we give you that option as well, and that's how you can find us.
Wonderful. Thank you so much. I've learned a lot, and I just appreciate your time so much.
Thank you for having me.
Absolutely. And to our listeners, wherever you are in the world, we wish you every blessing. Bye for now.